Welcome everybody to another VITA Learning webinar. Today we have Dr. Julian Conejo. Hi, Julian, how are you?
Hello, Jim. Doing great, thank you.
Excellent. How is UPenn? How's Pennsylvania treating you?
It's been pretty hot last week. Today's better, but we had a very hot past weeks. Yeah.
Wow, you got the heat soak too, huh?
Yeah.
Well, today, thank you for coming and joining us today, Dr. Conejo. Greatly appreciate all the wealth of information and you sharing it with our audience through the webinar and so forth. Greatly appreciate it. Today, Dr. Conejo is going to talk about the single anterior dilemma, managing aesthetics for the end result. Before we get going, though, just a couple reminders as far as the webinar goes. Everyone's phone, you're on mute. So if you have questions, there is a question box that is within that panel on the right-hand side of your screen. Just pull that out, open up the question box, type in your question, and then send it. And then at the end of the program, we will go ahead and answer some questions. Also, the workshop will be recorded. The webinar you'll be able to go back and revisit. It is located on our VITA North America YouTube channel and some of our other social media outlets, YouTube, LinkedIn, Instagram, and Facebook as well. So you can visit those and also watch Dr. Conejo on some other recorded webinars as well that we've done in the past year. Today it happens to be the anterior and managing the aesthetics, the end result. And Dr. Julian Conejo, he obtained his doctorate degree from the Universidad Latina, Costa Rica in 2005, completed training as a prosthodontist at the Universidad Intercontinental in Mexico, 2008. He's a visiting scholar at the Department of Preventative and Restorative Sciences, University of Pennsylvania, Philadelphia, UPenn. He practices clinical dentistry and conducts extensive research at UPenn. He's currently the clinical CAD/CAM director, so Dr. Conejo has worked in the areas of digital dentistry for many years now, including now dentures as well, removable stuff. So he's got a wide, extensive knowledge base of digital as well as clinical applications, restorative dentistry. From his research and experience, Dr. Conejo has written several peer-reviewed articles and studies. And with that, I'd like to introduce you, Dr. Conejo, to the group, to the audience. And we can start our presentation. I will now turn the webinar over to you as the presenter. And you are now the presenter. So we can see your screen.
Mm-hmm. Okay, I think we're all set, Jim. Thanks for the kind introduction. Yep. And thanks again for having me with the whole group from VITA North America. It's always nice to share new content as we work on ceramics, CAD/CAM dentistry, and specifically on aesthetic dentistry. So when we put these programs together, Jim and I discussed that it's always a challenge to do high-end anterior ceramic restorations, and we have so many good material options and great CAD/CAM technologies and softwares, but there's still many concepts that we need to have very clear, whether we're in the clinical scenario or in the lab, or we do both. So today we're going to talk about the single anterior dilemma, as it is something very challenging, I think, for everyone involved on dentistry and aesthetic dentistry. So sometimes we could have vital teeth that have anterior failing restorations, or we can have non-vital teeth that have already severe discolorations. And basically, that's one of the key complications when we have a substrate that it's very dark. And also, aside of the state of the abutment itself, for me, one of the main things that I see many clinicians maybe not paying that much attention before you start working with the case is space distribution, right? So whenever we've spent time in the lab doing manual wax-ups and we try to match one side with the other, and we can see that there are discrepancies between the right side and the left side, we need to start being creative to try to make that difference look smaller. And many times when we are working with CAD/CAM systems, whether it's the clinician or the technician, we get going to the production of the final restoration without a proper analysis of space distribution. So that's my key message for today. Before we start with the preparation, the scanning, or the designing, milling, and finishing of the restorations, we need to check and try to really have a detailed measurement and understanding of the available prosthetic space. Because what I believe is that we should be very good at making difficult cases easy to be able to resolve them at the first attempt. But if we're trying to always solve difficult cases right away with indirect ceramic restoration, maybe we can get into trouble. So we will go through this, and I have cases included today on different CAD/CAM workflows. As Jim said, I'll show what I do as a CEREC dentist, let's say it this way. It's already been 12 years and a half that I've been working as a chairside CAD/CAM clinician, but also I understand my limitations, and that's where I need to partner with master ceramists, people that can really have that ability to mimic the adjacent teeth. And I think also a very important take-home message, at least from my perspective after these years doing this, I need to understand my limitation as a CAD/CAM dentist. Maybe nowadays 80% of the restorations I feel comfortable doing it and like the final outcomes, even in the anterior zone. But maybe that's this other quarter of the cases that I need to work as a team with a high-end ceramist to be able to solve more complex cases. So I'll be showing some of those two different workflows, and I will only present today what I really use on a daily basis for anterior indirect restoration. So in past webinars, I've shown some cases that we do with a resin matrix ceramics, specifically with VITA Dynamic, which is a hybrid ceramic. Today, I would like to show what I do with the VITA Trilux Forte, which is the first block of Felspastic ceramic, now in more of bleaching shades as well, which is something great because many of our patients want teeth brighter or their adjacent have been bleached before, and we need to adapt to that color, and also work on the oxide groups on zirconia. And in zirconia we have two worlds, right? The world of the monolithic solutions as a clinician, which now I like more and more the results that I obtain, and also the work with a lab technician with a partial cutback and ceramic layering on the facial aspect. Okay, so going to the second part after the treatment plan and analysis of space distribution, it's the detail that we put on the preparation. So when I'm trying to prepare a tooth, I'm thinking of two things. One, path of insertion, which I use these burrs that we design with Praster, and the other one is to create that space for the material. I think those two things are the main factors why we prep teeth. To create a path of draw, path of insertion of our ceramic or zirconia restoration, and to create the space for that material in harmony with the concept of space distribution. The other aspect that is very important is to be very gently with the soft tissue. So we need to have better instruments for soft tissue retraction and soft tissue protection, because no matter how good your ceramist, the layering, if you created a recession, if there's swelling of that soft tissue around the restoration, the case is not going to be successful. So we make sure that we understand the importance of managing the soft tissues to have long-term clinical success. And then nowadays, magnification is something we do work with on a regular basis, whether you have high-end magnification loops around 3 to 5 times the magnification, that's something needed, or if you have access to a microscope or checking the preparation quality is super important, mostly when you are doing milling of your restorations, because we understand that the accuracy of that restoration will totally depend on the quality of the prep. If my preps are not clean, are not nice, smooth, detailed, my marginal adaptation is not going to be the best. The amount of spacer of the intaglio surface is going to be more because the software needs to compensate. And maybe when I'm working with thin restorations, that's going to show through. I could see some like islands on the facial aspect of a restoration because the material thickness is very reduced in that specific part, and you see more of the cement. While in the cervical or middle third, you could have more thickness of the material, and then we start questioning why I see slight differences on the facial aspect. So those are things important to consider. I know that traditionally many people were thought to use coarse diamonds to prep teeth, so they were getting a better retention of the cement for the restorations. But nowadays we know that if we have a fine diamond burr that creates that smooth surface, and we can even use a extra fine burr to smooth out any sharp line angles in the preparation, we can have the best marginal adaptation possible and have very nice results. And with a clean marginal adaptation, soft tissue health will come always after it. But in the other hand, if you have a bigger gap and you have excessive cement there, then of course the inflammation, the cervical retraction, and the problems on that soft tissue around the restoration will also come after a few weeks. Okay, so working with VITA for almost 13, 14 years now, we understand the importance that they put on shade matching, right? And here we need to differentiate whether I'm working with a monolithic solution or I'm working with a fully customized solution. So that's why we want to have both alternatives. Some cases are much easier than what we're seeing here, and maybe with a good selection of that block based on the VITA 3D Master principles of value, I already have maybe 60 to 70% of the success, and then I might play with the positioning of that restoration inside a polychromatic block, and then I can use the external stains and have something that looks really nice in the patient's mouth. But also, if I'm working with a more aged type of teeth that has more internal effects and more customization on the inside, so that's where I need to team up with an expert dental technician. So shade selection needs to be done always at the beginning of the appointment, because we have a short window, maybe 5 minutes before teeth start dehydrating. Nowadays we use technology like the spectrophotometer. We also have plenty intraoral scanners that help us also capture the color, but I still rely on photography with the shade tabs in combination with the easy shade. So the two in the right, the middle photo and the right photo, that's what I do on a daily basis for all the cases that you will be seeing today. So let's start working today with Felspastic ceramics. As I was mentioning, Felspastic ceramics has been since the start of CAD/CAM technology, starting as a monochromatic block. And now we have the VITA Trilux Forte, which is the same Felspastic ceramic, but with that diffumination. Before, it was only available in let's say, more chromatic groups like group 1, 2, 3, etc. But now we also have them, as you see in this photo, on the 0 group as well. Why? Because sometimes nowadays patients bleach a lot and we need to match those teeth, or they want to do bigger full mouth rehabilitations with brighter shade. So it's the most translucent material. It's not the strongest one, but if we bond it properly, it's sufficiently strong to work perfectly, and it's a polychromatic material. So the amount of external staining that I need to do as a chairside dentist is less, or the amount of ceramic layering as a dental technician also is less, because the block already has that diffumination of chroma between the cervical and the incisal third. So what's my main use for this material? Porcelain laminate veneers. This is my go-to block for the past 12 years for every veneer that I make. And anterior crowns when the color of the abutment tooth is, let's say, ideal, when I have a vital tooth. Because with a discolored, severely discolored teeth, this excess of translucency could be actually an issue for obtaining clinical success. So I'm going to show this first case. I think we've discussed this case before, but here you see number 8 with extensive composite restoration, and this is endodontically treated tooth. So here we go, remove all the composite, and we prep the tooth. It had a wide access on the palatal part, and we make this tooth preparation. So for Felspastic ceramics, I want you to pay attention to the incisal edge, how it has rounded transitions towards the mesial and distal walls of the abutment tooth. We have a 0.8 millimeter thickness of shoulder with an internal rounded angle. I use my burr plug from Brasler, and the 8847 KR burr gives me this type of margin. And actually, I don't have that J type of margin with unsupported enamel. Actually, it's a nice and clean shoulder with an internal rounded angle. I place my second cord, and then when I'm ready with the scanner in my hand, remove that second cord, dry, and start scanning. So with this double cord technique, I haven't changed anything since I started with PVS impression materials. I scan clearly the abutment and the adjacent surfaces. Okay, it's very important that in the mesial and distal you place your margin 0.5 millimeters subgingivally, so when you design that, you can design and start from underneath to create a nice emergence profile and give support to the soft tissue and avoid black triangles. Okay, so this is an ideal case because the space that I have for the crown is symmetric to the adjacent tooth. So the only thing I need to do is pay attention on the position of the incisal edge, the position of the line angles, the bulkiness of this restoration. That's why I use a preparation guide to make sure that I'm creating homogeneous space on the 3/3 of the facial aspect. And then my hand skills, my ability, or the time that I have to remove the sprue and start defining those line angles, and then start pre-polishing this, then go for stain and glaze with the VITA Accent Plus kit. And then you can see here the nice results at delivery of this type of restoration. So let's pay attention not only to the contours, the external part of the crown, where it has very symmetric width and length, but also on the light reflection. You can see the mesial and distal line angle being very symmetric with the contralateral tooth. And then the incisal third, I added a little bit of that white stain, a little bit of light gray, and we can have something that is nicely customized. And this is done by me as a clinician, done chairside in one appointment. Maybe this takes me a few hours from start to finish. But if we prep properly, we follow the 3 planes, we can have a homogeneous thickness on the facial aspect around 0.8 to 1 millimeter on the 3/3, and then we're going to have a nice soft tissue adaptation on the follow-up appointments, because we are not prepping excessively subgingival and not violating the biologic width. Of course, it's important after glazing as a CEREC dentist or chairside dentist to polish after glazing. So we kind of reduce a little bit that excessive gloss and have a nice natural surface. So I put together this slide this morning to talk about the importance of space distribution when we are working on anterior aesthetic restorations. Many times we have what I call tunnel vision. We are thinking, in this case, tooth number 10, I have an implant, I got to work on this lateral incisor, and I got to work on the impression, I got to work on the shade selection, and so on, right? But we have to take a step back and we have to avoid having tunnel vision, and we have to see the whole picture. So I like to take a look to the contralateral side, measure the number, in this case, number 7, measure the mesiodistal width and length of the other tooth, and then use my ability and your ability with direct composites that we use every single day to idealize the restorative space, to have the ideal space distribution. Sometimes when teeth has been extracted and there has been implants placed, even though sometimes we do grafts, there might be some lost soft tissue or bone around it. So a very, let's say, tapered shape of tooth, a very triangular shape of tooth will, adjacent triangular teeth will obviously have more chance that when we place our implant restoration, we're going to finish with black triangles. Okay, so here we need to kind of, I wouldn't say cheat, but we need to take the benefit of the combination of indirect and direct restoration. So for these areas, I'm going to etch the enamel, apply a little bit of the bonding agent after I place a retraction cord. Here I'm only using the Ultragate, not a full rubber dam isolation, very cooperative patient in this aspect, so I can apply the bonding agent, air thin it, light cure it, and then apply a little bit of composite in that proximal surface of both teeth to idealize that surface. So when we design the implant restoration, we have an ideal design of the contact point, and we also have a longer contact area, let's say, to be able to avoid any black triangles. If we don't pay attention to these details before we send the case out to the lab technician will always need to provide a proper path of insertion. So if we have teeth that are very tapered, that there's slightly loss of papilla adjacent to them, they are never going to be able to, let's say, close those black triangles by adding porcelain, because if they do that, then the restoration won't fit, won't be able to be inserted in its final position. And I know this is pretty basic, and some of you might say, well, this is too obvious. Yes, I know, but many times when I'm in the lab, I receive the cases, I'm like, wow, here with a little bit of composite, with a little bit of tooth contouring, the space distribution could be improved significantly, and then it would be much easier to create a perfect restoration that has the exact same width that the contralateral tooth. So that applies to centrals, that applies to laterals, to canines as well. So this is something important that we need to work on. Of course, we need to have very fine instruments. This is a ultra fine needle point burr that I use to smooth that composite in the proximal surface and to remove any excess on that CEJ area, so we don't have any problems with that aspect. So you need magnification, you need to take your time, then use sandpaper to smooth that out, and then pass the floss to make sure that it's not catching, and you will see how the soft tissue will react. So here I was not ready to load the implant at the moment, so I placed my provisional but I already have this exact space that I need for these future restorations. So always try to think about space distribution, combine indirect and direct materials, and you will make your life much easier when having that final restoration. Okay, so now we're going to move into the possibilities of zirconium oxide for anterior restorations. Dr. Blatz, my mentor, our department chair, has been working with zirconia for more than 20 years, and he has been doing a lot of research. Nowadays, we know that we have multiple types of zirconia, ones that are more strong, ones that are, say, in between, that could be used as monolithic solutions, but also as long span FTPs. And then we have the, let's say, ultra translucent or extra translucent zirconia, which are more in a cubic phase, and they work mostly for single restorations. So after I joined the department here, I started working with a few different monolithic zirconia products out there in the market, started to test them, and no matter the brand, what important was to understand the difference. So whether it's the VITA ST or VITA XT, which is 4 or 5% of yttria, those materials are going to be significantly stronger than lithium disilicate. So wherever you have a situation that you cannot bond properly, that you cannot have a nice chamfer, a clear finish line, I see that zirconium oxide is a great alternative also for subgingival areas because it's much biocompatible than traditional glazed ceramic material. So now we have, for those of you that do chairside milling, the VITA YZ ST multicolor block that can be used in the Cerex Speedfire with a speed sintering cycle. And actually this same block is marketed in the US as the Cerex MTL Zirconia by Dentsply Sirona. So it's exactly the same product here, but also we need to understand that zirconia also has certain indications and we need to follow certain thicknesses. So we can use 0.8 for anterior crowns, we can use 1.0 for posterior crowns, and 0.4 for laminates. Okay, ideally we would like to have a chamfer. We want to avoid J margins because that unsupported enamel can chip. We don't need to be so invasive and go with deep shoulder preparations. That's why that was needed when you had a coping and then ceramic for the shoulder region, but not for this type of monolithic zirconias. The knife edge or feather edge, still many manufacturers says that it's not ideal. We understand why. There's more risk of fractures in that area, but zirconia is pretty strong and behaves pretty well. If I had to do a knife edge or feather edge, I would definitely select zirconia before traditional Felspastic ceramics. Of course, avoid undercuts, as we need always a path of insertion. No rough margins. As I said, the importance of magnification is key. We don't need grooves. Nowadays, we can bond this as well, and always provide certain taper for an easier cementation and avoid sharp incisal angles, as we discussed before. So this is one of the first cases that I was trying the VITA YZ ST multicolor block, and we were able to publish this with my good friend Fabio Andretti on the book Digital Dentistry in Brazil with the Quintessence group down there. And it's basically a single central number 8 with endodontically treated wide access. And here is the important part. We need to always start selecting the shade at the beginning of the appointment, okay? Once we have that, I want to take photos, and sometimes I'm between two colors. In this case, I was in between B1 and A1, so I want to make sure that in my photo I see both shade tabs, both teeth that I'm considering, the one that I'm going to be treating and the contralateral, and that I see the letter and the number on the shade tab. This sounds basic, but it's super important. And then I place this photo in the black and white format, and from here I go and select the final shade. So in this case, I went with an A1 block. Okay, as I said, we're going to prep this tooth with an internal rounded shoulder, but also use the football shaper to prep properly the cingulum, the palatal surface of that tooth. At simple view, sometimes I check a prep and I say, well, it's perfect, but when you scan it and you go through the preparation analysis tools, I always find things that I can improve, whether it's the intraocclusal space, any minor undercut, some irregularities on the shoulder, and that's where I always go back immediately and refine that prep, because this is the best time to do that. Patient is anesthetized, we are already there, retraction cord is placed, and this will make the final trying in the delivery of the restoration much easier. So here I feel that I still need to work a little bit more on the incisal third of that preparation, but the cervical third and the middle third, the space distribution is pretty good. Then we go ahead and start marking the margins. I always like to mark the margins with the patient next to me, so I can check if I have any doubt. I can check it clinically right there, and then save the file, and then someone can take over and send the case out if we're doing that, or continue with the design. So here I'm showing the CEREC MTL Zirconia version of the same block, which is the same VITA material. That's why you see both logos on this block. This block is distributed by Dents by Sirona in North America, but I believe that changes within different markets. So that's kind of the explanation, but it's the same product. The good thing is that it's in there for the use of the Speedfire, which I think it's a great furnace for sintering zirconia. Maybe not my favorite for staining and glazing very thin Felspastic ceramic veneers, because it's an induction furnace, it's pretty strong, but for zirconia sintering, I find it very, very reliable. So the other factor that it's important when we're working on single centrals is not only the shade selection, the space distribution, but also the thickness of the material. If we're trying to be a little more conservative and maybe just prep 0.8 of a millimeter, the effect of the cement is important. I most of the time use the Panavia V5 resin cement system, and I like that it has the drying paste. So in this case, I start with the universal A2 drying paste, apply it inside the crown, sit the crown completely, remove the excess of the drying paste, and this gives me a good stability of the restorations as well. If I want to observe any details on the incisal edge, see if the restoration could be slightly longer, and also have the patient evaluate the restoration without the restorations flying around, right? So that's why I always use drying pastes. I believe that you got to follow nature's design. I like to have a proper selection of the shade of the tooth, but if possible, try to use the universal A2 resin cement or the transparent resin cements. I don't like to use opaque resin cements, as I never seen opaque dentin. But if we have a brighter color on the outside, well selected, you can still use these natural looking cements, and then you will see that warmth and that naturality on the restoration. So I think that today in 2022, the aesthetic outcomes that we can obtain as clinicians using monolithic zirconia are very good. Of course, we need to get trainings on surface texture, how to modify the position of a line angle, and of course, as I said, have that general view of the space distribution before you start prepping the tooth, before you start scanning, because sometimes you could help yourself using direct composite restorations whenever needed and idealize the space for your final ceramic restoration. Okay, so here, this is another, I would say, very complicated case, not only because of the discoloration, but of the position of this tooth, basically totally palatal oriented, related to number 10. And here is another example of the importance of using direct composite materials to enhance and improve the surroundings of your indirect restoration. Yes, today we're talking about ceramics, we're talking about zirconia, staining and glazing, but look how we can improve that scenario with this direct composite material here. Then I'm going to do the preparation, do the scan, make the design, and here I like to use the grid mode to check the detail of my design based on the opposing tooth or contralateral tooth, I'm sorry, and then go to the milling process. What I want to mention here is that I really like the marginal adaptation of monolithic zirconia compared to lithium disilicate, because here we're milling that restoration to 20 to 25% bigger than its original or final dimension. So those burrs turn to be thinner and you see less over milling on the intaglio surface. If you want to show me a good prep, show me a very nice and clean intaglio surface. So here you can see the detail. This is milled with the Cerec MCXL machine. You can use fast milling mode. I'm one of those crazy people because I'm going to get the restoration done milled faster by 2 minutes. I prefer not to have any issues on my margin and have it sealing pretty well 360 degrees around, but you can do fast milling if that's something you like and you consider important. And then we're going to do, of course, the stain and glazing. As I said, I like to use the VITA Accent Plus, and then manual polishing. And for zirconia, everything that is subgingival, we want to hand polish. So you can see here on that, let's say 0.5 cervical portion that it's subgingival, how we polish it with a dialite kit from Brasler. It's a 2-step polishing kit, and that will give you a very nice soft tissue adaptation to your final restoration. So this is the day of the delivery of this restoration. I think at this level of magnification looks good. At any social distance, it looks very, very natural. So I'm still waiting to see the patient again, maybe contour slightly more the incisal, the mesioincisal edge of this tooth, which I feel is a little bit long, but these things clinically I cannot perceive. I only perceive this when I go here to my computer, show the macro photo, and throw some lines in there. But the combination of this type of indirect resins on the adjacent teeth and optimizing the space distribution makes the final outcomes much better. And I want to finish with a more complicated case where I know that I don't have the ability to solve it by myself. We published this, our team from Penn Dental Medicine, in the Quintessence Dental Technology in 2020. This young patient came with an existing crown on number 9, which patient complained the crown was bulky, and also he didn't like the diastema. So we don't limit the photos intraorally, we also take extraoral photos, because many times we want to have that facially driven treatment planning option. So here I can tell that number 9, that crown looks wider than number 8. I can tell that there's a diastema. Those are 2 things that are the aesthetic concerns for my patient. And if I just cut that crown out and replace it, maybe I'm going to do the same. Or if I close the diastema only by means of number 9, I'm going to finish with an extremely wide crown on that situation. So here I'm using one of the apps available for digital smile design. I'm going to upload the STL file from the pre-op scan. I'm going to upload the photo of the patient in high smile, and then I'm going to start measuring. We have different templates so we can understand what's the space distribution for this case. Here as I was explaining at the beginning, I use the Easy Shade, and I like to also use their app, which is called VITA Mobile Assist. So with the VITA Mobile Assist, I can then connect by Bluetooth the VITA Easy Shade to my cell phone, and then paste the information of the spectrophotometer on top of the photo. So when I'm sending out a case to a dental technician, this is really helpful. Here it tells that the body of the tooth might be around a group 2 or an A2, but you can see the differences on the incisal third, where there's less dentin, where there's more enamel, the tooth is thinner. So these are very good aspects to share with the lab technician, not only the photo, but the information from your Easy Shade. So in this situation, I remove the crown, just soften the preparation a little bit, and explain to the patient that in order to have symmetry, to get rid of that diastema, but have both teeth having the same length and width, we needed to work also on tooth number 8. In this case, I prepped a veneer, and this veneer wraps around in the mesial surface. Why? Because I want to have that freedom to idealize the midline position. If I just stay facial on my veneer prep, I won't have the possibility to move that midline and create that nice relation between both the central incisors. So these I sent out to Michael Bergler, who's part of the team here at the Department of Preventive and Restorative Sciences, and Michael, using the Zirconium software, designs from outside in. He starts designing this full contour, but we know that one is a veneer with a big abutment and one is a crown with a much smaller abutment tooth. So for this purpose, we like to use a technique that has been around for many, many years called the rapid layering technology, which we will be milling a Felspastic VITA Trilux veneer, and we will be bonding it into an anatomical coping. This way, I can compensate between the difference of the abutment teeth, and we have done clinical research here at Penn with excellent clinical results because there's much less risk of chipping. This was presented in 2016, started around 2013, so this is data that has been around for a long time. So what you see here is the design of the anatomical coping, trying to simulate as much as possible the veneer prep. And then we have 2 VITA Trilux Forte Felspastic veneers on top, one on top of the tooth and one on top of these anatomical coping. Why I want to show this, because it's important to understand as clinicians my limitations and also have the ability to work with an expert. And here we want to bond this, the Felspastic ceramic, to the zirconia coping. As Dr. Vlatz explained when he published the APC concept, we're going to air particle abrade the zirconium oxide. We're going to apply a specific primer that contains MDP, and then we're going to use a composite resin cement. So we use the Panavia V5 system in these situations. You can see the zirconia coping after air abrasion. Immediately after, we apply the ceramic primer plus. On the side of the VITA Trilux Forte veneer, we etch with hydrochloric acid for 60 seconds. We wash and dry with ultrasonic in alcohol, make sure it's nice and clean, and then we apply the same ceramic primer plus, which in this case is acting as a silane coupling agent. Okay, for Felspastic ceramics, there's silica-based ceramics, we need a silane. And then we apply the cement inside the veneer and bond these two extraorally, excuse me. So by doing this technique, I'm able to assure that I'm removing all the excess of cement, and actually I can polish very well that interface between the Felspastic veneer and the monolithic zirconia coping. And then you can have a very nice final result in these type of cases that many times they might not look so challenging, but then we try in the restorations and we know that the patient maybe was expecting something better, or we are actually not so hyped about the result achieved. So these are alternatives. I'm not saying that you need to use this technique every single time, but this is knowledge that you want to have there. This is a broader armamentarium of possibilities. So today we've gone through 3 different cases, right? The first one with the use of a monolithic VITA Trilux Forte crown with stain and glaze only. The second technique method was the monolithic zirconia, which would be better to use it also when you have moderate tooth discolorations, as it's less translucent than the pure Felspastic ceramic. Also, we've talked about the importance of space distribution and making sure that we avoid having a tunnel vision on the treatment planning phase, but we want to see the whole picture and use direct composites to help improve and idealize the space for my final ceramic restoration. And then when we consider that it's a challenging case or a patient with a higher aesthetic perspective, then maybe my ability as a chairside dentist might not please that patient, I want to work as a team with an excellent ceramist. But in that situation, not the amount of information, but the quality of information that I share with the lab ceramist is very important. So I want to share the portrait images, I want to share the pre-op STL file so they can align those two together, simulating what we do with the face faux, and start doing that ideal digital wax up that then we can print or they can send to us and create those prep guides to assure that I'm having an ideal preparation following the 3 planes of the tooth, of course using the football shape in the cingulum and a very nice margin, slightly subgingival in the mesial and distal, so we can have this type of soft tissue condition around our restorations. So I think it has been a nice review of different techniques, different workflows with some of the VITA materials. And as I said, these are concepts that apply to every type of material, whether you're working on your PMMA provisionals, space distribution is crucial. So I always want to finish with 3 short conclusions. The first one, work more on your hand skills. If we are critical and if we are honest, we see many different quality of restorations made with the same material. So I don't really believe or think that the material is the difference in 100% of the situations. I think that it's very important how the operator understands the material and knows how to work and how to achieve the best results with any material. Okay, so work more on your hand skills. Still, we do dentistry with our hands, and we need to be good at this. The other aspect that I always mention is use material-specific instruments, and we've developed a few kits with Brasler, and there are many good options out there as well. What I would like to always explain is that many times we have a fracture on a ceramic, and we always, blame the ceramic material, right? But it might be that we were working on this material with the wrong instruments, and we actually caused this stress on that material. And after a few months in function, or even weeks, or even days, then patient comes with a fracture. So it's important to have a kit to finish and work zirconia, another kit to work on silica-based ceramics, and of course on polymers or acrylics, as you're seeing here, right? Because the quality of your provisionals, the quality of the polishability of those restorations on the cervical aspect will totally define that surrounding for your final restorations. If you don't like how it's looking at the provisional stage, it won't improve magically for the final restoration. So this is important to understand, train your staff on how to maintain these kits and have them always use the same instruments. That's how we get much better. And then always deliver what makes you proud. Many times I've heard from maybe some students or colleagues, well, this patient had very low aesthetic expectations, but as professionals, as clinicians or good dental technicians, we should have very high aesthetic and functional expectations for every single case we do. So this is an example of a fully layered zirconia crown. This is a porcelain infused zirconia restoration made in Japan by master dental technician Yamada. And for me, this is artistry, right? I totally understand my limitations as a clinician, but I do know that with the materials available today, with my training, I can tackle, as I said, maybe 75 to 80% of all the anterior restorations by myself. But I don't want to try to work on 100% of those cases. I think that combination of workflows is what will give us the best long-term results. So it's 12:52, so we can break it here. So we have a few minutes for Q&A session. I would like to share my email. It's jconejo@upenn.edu, and my dental Instagram account, dr.julianconejo. Here I share a lot of information, publications, tips, photos, basically on aesthetic dentistry, implant dentistry, dental photography, and so on. So I'll want to invite you to follow the account. That way we can keep in communication. If there's any questions you guys have regarding any case, want any feedback, want access to any paper you might not found, whatever, don't hesitate to shoot me a personal message there, and I'll try to respond and help with whatever it's needed. So Jim, thank you so much for the invitation today. I think that this is always a very exciting topic, as it's always challenging, but we were able to at least explain three workflows, three different alternatives, and I hope it has been beneficial to you guys today. Thank you.
Oh, tremendously. Thank you, Dr. Conejo. Greatly appreciate all your knowledge, all your scientific background as well. I mean, it's ideal to also bring in the study, the test data as well. And obviously at UPenn, you get an opportunity to kind of test out, prove out your theories, and prove out what the best practices are. So thank you for sharing those. Before we get to the questions for everyone that is asking about CE, it will be processed. Give us a couple of days. We will use your information that you registered with to process your CE. If you don't see it in a couple of days, then go ahead and give us an email at the education at VITA North America. The workshop, the webinar has been recorded. That will be posted on our VITA YouTube channel. Please come visit us. As mentioned earlier, Dr. Conejo has several webinars that we've done throughout the year and last year as well. And those are all posted that you can go visit with different various topics, including digital dentures as well. The social media, YouTube, LinkedIn, Facebook, and so forth, all of that information, additional educational opportunities will be on those websites. If you need to get a hold of one of our reps, whether you're in Canada or the United States, here is some information for you. Please feel free to give them a call and ask whatever questions you need, you're inquiring about, whether it's about education or whether you need someone to come see you, visit you at your clinic or laboratory. We have several webinars, remote webinars, and workshops going on throughout the year. We're trying to work something out now with Dr. Conejo to actually do a hands-on. I know that that's always a favorite. So we're trying to get the dates and, the topic and so forth. So if you do have specific topic that you'd like to see hands-on, please let us know here at VITA, or go ahead and email Dr. Caneo as well, and he can forward that information to me, and we can try to put something together. But please visit us again for future webinars and workshops that we have scheduled. If you need to get hold of the help desk here at VITA North America, here is some information as well. Paul or myself can help you out. And also you can just email us at thehelp@northamerica.com. And then of course, Dr. Caneo was gracious enough to provide us with his contact information. So, you know, give Dr. Caneo, if you email him or try to contact him directly, make sure that you give him a couple days to respond. He is tied up with a lot of various programs and so forth for the school. So, and he also takes vacation every once in a while, is what I hear. But you know, give him a couple days to respond, and he can do that. So as far as questions go, let's start off. One is, how long do you etch your feldspathic milled restorations? So you first, let's say, what's the etchant you use, and how long do you leave it on your feldspathic porcelain, veneers, or crowns before you bond?
Sure. So we know that feldspathic ceramic is a silica-based ceramic, and it has a glassy matrix and a crystalline face, but it's so translucent because it has a very high glassy matrix. So we want to remove part of that glass. That's why we need to etch feldspathic ceramics for 60 seconds, okay? There are many studies that support and show that you could etch feldspathic ceramics from between 60 seconds to 120 seconds. So between 1 minute to 2 minutes, that would be an appropriate time. VITA, as a manufacturer, recommends the etching of VITA Trilux Forte or feldspathic ceramics for 60 seconds. And that's actually what I do. 60 seconds is sufficient, and we can use the VITA ceramic etch. And also you could use a 9% hydrofluoric acid etching if you maintain it for 1 minute. So both would be indications. What I do personally, what we teach here is hydrofluoric acid etching 5% for 1 minute. Would you like to add anything to that, Jim, on the availability maybe of the etchant, or other etchants are available as well?
I think you covered it. Always look at your manufacturer, the material manufacturer's instructions. Make sure you use the right percent of hydrofluoric acid and the process. And when they say anything that says 60 seconds or 20 seconds or 30 seconds, that's when you actually should be getting close to actually rinsing it off. So if you over etch it, there's issues to that as well, right, Dr. Caneo?
Yeah, absolutely. So what Jim is saying, having the timer there, it's important. Those small things make the difference. That's something I always use. Have my timer next to me and be ready with my air water syringe to rinse it up at the exact time. So that's a great question. Just as a summary, if we're using VITA Enamic, which is a hybrid ceramic, remember that this is also a feldspathic block infiltrated with composite, so it needs hydrofluoric acid etching, and the recommended time is also 60 seconds, okay? So if you want to use Enamic, you don't need to learn 2 different times. It's exactly the same, 60 seconds for both Enamic or feldspathic ceramics.
And that's also, since the question came up as well, prior to etching, how do you clean your restorations?
Yeah, so that's a great question. As Dr. Blatz explains, always we always want to start the bonding process from a clean surface. So you can take out the restoration from the patient's mouth and then put them on ultrasonic in alcohol for 3 minutes just to clean them well. Then take them out, and then you start etching, water, spray, and then you go with the application of the silane coupling agent, right? The Felspastic ceramic needs the silane, and then you're ready. Once I have my restoration etched, cleaned, silanized, then I go to the tooth side and start working on the tooth side, etching the tooth, applying the bonding agent, but I don't want to worry about the ceramic. It's already ready to be delivered.
All right. A design question on your contact strength. Do you usually do a slightly heavy, just in contact, light contact? I know that the digital is getting more accurate, but you usually polish them yourself?
Yeah, that's a great question there. And I think, Jim, the important aspect here is to understand if my finishing process for that restoration would be additive or subtractive. Let's say I'm working on a monolithic zirconia and I'm going to be stain and glazing. I will be adding a layer of glaze, which has a thickness there. So maybe I will just design a nice broad contact at a slight light blue with a little bit of green only, not too heavy. Actually, let's say minimal contact on the software because I know I'm adding a glaze. But let's say I'm using enamic. Enamic is a material that I cannot, let's say, put in the furnace, right? It will burn. It's a material that I personally, I like to polish only. So polishing is a subtractive technique. So when I'm designing enamic, I want to make sure I have maybe more green, stronger contact, because when I'm polishing and finishing is a subtractive technique. Different softwares, different milling machines. This question comes out all the time, but I would say have a model from a hands-on course that you had. Say the VITA model with a central and a molar. I like that one. And then I mill one crown of each material and I check the design and then I place it in and check the contact points. I write down on the clinical result that I obtained. I had to touch it or slightly soft, and then you get to that fine tune. I always think about Formula One cars and teams, right? They compete in USA, they compete in Monaco, they compete in different countries, in different heights, in different altitudes. They still need a few days to get that car ready, right? So that's what we need to do with our own CAD/CAM system and materials. It's not rocket science. It's just making 2 or 3 crowns, check one side, and until you get it. But that's why it's also so important to enhance the adjacent tooth, maybe a Softflex disc, use that composite that I explained to have a broader area, and you will have less complications of foot impaction, right? Which is always our concern on that topic.
All right, thank you. So you mentioned use for bonding, use Panavia. Are there any others you find work well, or is Panavia what you've
sorry, Jim, I lost you for a second there. Can you repeat the question?
For your bonding agent, you use Panavia? Can you hear me?
Yeah, for the bonding agent.
Yeah, so yeah, you use Panavia as a system.
Yeah.
Yeah. Is there any other that you find works well?
I mean, there are so many brands out there on resin cements, and you can use many other options. What is important is not to mix the components between the cement, the silanes, the bonding agents. They might be compatible or they might not, and we really don't know. So if you'd like to use, for example, visco products for resin cements, that's perfect. Make sure you use their silane, make sure you use their bonding agents. If you like to use 3M, make sure also that you try to keep it as consistent with each of those systems. I don't change from one cement to another, Jim, because it takes time to get an expertise, right? Same with the glaze, with the ceramic. If you're always like changing from one to the other, you don't know exactly the timing, when to remove excess, how this looks when you cement. So I always try to, tell my students, if you have a resin cement that you understand, it works for you, keep using it, because it's not easy to get that expertise. We won't get that in just a few crowns.
Yeah, that's true. Your margins, how subgingivally do you place them, or is it all dictated by the specific patient indications?
Yeah, that's a great question, right? So I do a facial analysis. If I have a 80-year-old patient with a very low smile line that it's not showing me more than the incisal edge, right? Can I stay slightly supragingival, 0.5 millimeters supragingival, and facilitate the scan, facilitate the hygiene? Of course, that's totally indicated, right? If I'm seeing a young patient in their 20s looking for a very nice new smile design with a wide, big smile, I want to make sure that there's no difference in the cervical third. So maybe there I will place always a 000 retraction cord and smooth the margin at the gum level with the 000 retraction cord. So this gives me a margin placement of probably no more than 0.5 millimeters subgingivally, and that blends very well with the tissue. So you don't have any complaints like, oh, I have a small recession, now I see the dark part of the root there. So I understand why this question comes up, and the smile line is something that we need to diagnose to make that decision. And if we're working in the posterior region, lower molars, for example, if I don't need to prep the whole facial aspect or lingual aspect, and I'm bonding that restoration, then that's perfect. Easier to place your rubber dam, easier to brush that that cementation line between the restoration and the tooth. I think it's multifactorial.
Another question: do you have a camera preference for your photos?
Yeah, so we use Canon DSLR cameras. Both Dr. Blatz and myself here. We use the Canon Macro 100 lens. All these photos are taken with that lens. And then the light source, it depends. If we're working on the anterior teeth, we used soft boxes that give you that softer light. If we're working in the posterior region, in molars with mirrors, we use ring flash with a diffuser. So I'm using a new diffuser now that I like. If you send me a message on Instagram, I can guide you directly to the link, whoever is asking me this question. But yeah, we need to have a diffuser always to get a nice light.
All right. And then last question, prior to sintering your zirconia on the outer surface, do you polish it, smooth it out?
Mm-hmm. So what I do first thing, as I get the zirconia crown out from the milling machine, I brush it. I brush the inside and the outside very well with a brush. I dry it well. I make sure that I have an air line that has no water there, so I don't have any risk of getting humidity there. So I dry it well. After cutting the sprue, I pre-polish that area very well and pre-polish the entire restoration. This is something that it's technique sensitive. That's why I'm telling always to Jim, think after a group of webinars, I would like to have a hands-on course, because green stage zirconia is like chalk. So if you don't have the good pressure, if you don't have the good instrument, if you don't have the correct RPM, you can remove too much. But also, if you see good technicians, they work in green stage, right? And that's what that comes nicer from the furnace. So yeah, I do pre-polishing of all the zirconia restoration. I'm very cautious on the proximal contact areas of that, and then we sintered. And after that, I like to use a combination firing where I stain and glaze, and that's it.
All right. Well, thank you very much again for your time today, taking time out and providing excellent education, excellent knowledge, background, statistics, science, to the audience and to the market. So greatly appreciate it. Any last minute comment you'd like to make before we close this out?
Yeah, don't hesitate to contact me if there's any other questions you guys have, or tips, or whatever is needed. I'm totally available. And stick with VITA North America for their CE education program, which is pretty good. I still have a few dates already scheduled with Jim and his team, and hopefully also we'll be having some more in-person events coming up. So thank you for your time, everyone. Jim, thanks a lot again. It's my pleasure.
You're welcome, and thank you again. Thank you. The information of Dr. Caneo is on the screen, so please contact him as needed. And I want to thank everyone for joining us today. And this will conclude today's webinar with Dr. Julian.